So next, we're going to enter into our rapid-fire research abstracts, and I'm pleased to bring Dr. Osborne up to the podium. He's associate professor at the section of vascular surgery at the University of Michigan, and he is chair of the Venous Research Council. Nick, all yours.
Thanks, Jens. So first up, we'll get started just in the interest of time. We're going to welcome Sina Zarintan to the podium. Dr. Zarintan is a postdoc fellow in the Division of Vascular and Endovascular Surgery at the University of California, San Diego. Welcome to the podium.
Good afternoon, ladies and gentlemen. Thank you for the opportunity to present. My talk is, thank you. My talk is about the impact of prior endovascular interventions on outcomes of intrainguinal bypasses performed for chronic limb-threatening ischemia using data from VQI Medicare-linked database. So we don't have any disclosures related to this study, but Dr. Molas was PI for the studies listed here. So, as we know, Basel trial was performed to compare the outcomes of open and endovascular therapies for patients presenting with CLI, and they found no significant difference in overall amputation-free survival and overall survival. However, for patients who survived at least 2 years, the open bypass was associated with a significant improvement in overall survival and a trend toward improved amputation-free survival. And the recent BEST CLI trial found that open bypass is superior to endovascular therapy in patients who undergo bypass with a single segment saphenous vein graft. However, for patients without single segment saphenous vein graft, there was no difference in terms of major adverse limb events in open and endovascular therapy. In a different study from our team, bypass with graft was compared to a stent in SFA lesions, and we found better outcomes in 2 years for stenting compared to open surgery. So the question is how the prior endovascular intervention is going to impact our bypass in patients presenting with CLI. So in a sub-analysis of Basel study in 37 patients who had prior endovascular interventions, they found that de novo bypass is associated with improved amputation-free survival compared to patients with history of prior PVI. A systematic review and meta-analysis also found better outcomes in patients undergoing de novo bypass compared to the patients with history of prior PVI. And a study from NESQUIP database found no difference in patients undergoing de novo bypass with patients undergoing bypass following a failed endovascular interventions, but the outcomes were just short-term. A single institute study looked at 300 bypasses with 2 cohorts of de novo and patients with history of prior PVI, and they found no difference in terms of 3-year amputation-free survival. So we wanted to look at this research question in real-world experience using data from Vascular Quality Initiative Medicare-linked database. So we used infrainguinal bypass data set, and we used data from 2011 to 2019, and we had 2 cohorts, patients with and without history of prior PVI. And we excluded patients with prior ipsilateral bypasses or prior ipsilateral major amputations, and also the urgent emergent cases and aneurysmal indications and indications for claudication. Our primary outcome was 5-year amputation-free survival and 5-year freedom from reintervention, and the secondary outcomes were 5-year overall survival, 5-year limb salvage, and perioperative outcomes, including MACE, male, and 30-day mortality. So we used one-to-one propensity score matching with 17 dimensions, and then matching was performed based on the patient demographics, comorbidities, prior procedures, and medications and procedural data. And then we use univariate logistic regression, generalized linear model, Kaplan-Meier, and Cox regression for the analysis. So we end up with 7,000 patients before propensity score matching, and then we had 1,500 patients in each matched cohort, in patients with and without prior PVI. So patients in de novo bypass group were more likely to be older. However, patients with history of prior PVI were more likely to have history of coronary artery disease and prior contralateral procedures and the use of P2Y12 inhibitors. And patients undergoing de novo bypass were more likely to present with tissue loss. So in terms of perioperative outcomes, either before propensity score matching or after propensity score matching, we didn't find any different results. For 5-year overall survival, as we see after propensity score matching in 2 cohorts, in patients without prior PVI, the overall survival was 47 patients versus 51% in patients with prior PVI, then the difference was not significant. And for 5-year limb salvage, again, the limb salvage was around 80% in 2 cohorts, and amputation-free survival, no difference. And also 5-year freedom from reintervention, around 59% in de novo bypass versus 57% in patients with prior PVI. So this study was limited like other retrospective studies in terms of non-random allocation of study groups and other unmeasured biases. So in conclusion, this propensity score match analysis revealed that bypasses performed in patients with prior endovascular interventions have comparable 5-year outcomes compared to bypasses performed in patients without history of prior PVI. So prior endovascular intervention also didn't affect the perioperative outcomes. So we conclude that prior endovascular intervention should be still considered for the limb salvage with autogenous grafts. However, the safety of endovascular first approach should not preclude first bypass strategy in all patient populations presenting with CLTI with adequate vein grafts. Thank you, and I would be happy to take any questions.
But I have a question for you. You know, some of the people in the room will probably know who John Porter was. And John Porter saw a table like this. It was a live table analysis. And he said, you know, half the people are dead. So when you're presenting this data, you know, some of those people just fell off the chart. I don't actually think that reflects patients with chronic limb-threatening ischemia. Most of those patients die within 5 years. So can you say that you had 100% survival? And what would it be if they dropped off the curve if they died? Because it's really not the typical patient that has chronic limb-threatening ischemia that lives 5 years. So when you have 70% patency, that's shocking. Half of those people might be dead. So I mean, that was John Porter's comment, and I think it holds true today. I'm curious what percent of those patients died.
Oh, yeah. So, yeah, because, thank you, great question. So, because most patients in Medicare Link database are above 85 years, as you mentioned, have higher mortality rate. And so when the patients die, we don't know how it will affect the estimation of limb salvage and reintervention. And it is, of course, a potential limitation. Thank you for mentioning this.
Hi, Phil Goodney again. I enjoyed just your talk, and it's nicely demonstrated data. You know, your crude results showed a modest difference that resolved with propensity matching, suggesting that, you know, some of the differences in the outcomes were likely due to characteristics that were different between the two populations. Of course, there's some patient selection here at work. So, you know, how do you think then the surgeon should, you know, those people who chose to do something first probably had a reason behind their decision making? So how do you plan on helping to inform people before the cycle starts? You know, how is this information best shared so that we can, you know, help people make the best decision in the first place?
Yeah. Thank you for the question. So yeah, actually, as we know from the recent best CLI trial, open revascularization superior to endovascular therapy. However, in real practice, we see many patients that are undergoing endovascular intervention, especially with other specialties than vascular surgery. And now we need to decide for them. So I think this, the results just shows us that the outcomes are not as bad as we may think in a patient with prior, for example, stenting or other procedures done, and we should still consider doing bypass for them as the standard and superior therapy. Thank you, though.
Thank you.
Thank you.